I'd like everyone to welcome Dr. Rick Wallace with us this morning. Dr. Wallace is the Assistant Director of the ETSU College of Medicine Library and Professor at the college since 2012 and started with the university in 2001, right. 15 years ago. Has a very extensive CV, over 100 presentations, a few dozen publications, and many awards for his outreach with the College of Medicine Library and with library sciences. And also has the impressive fact that he's hiked over 2,000 miles of the Appalachian Trail, which is a great feat. So thank you very much for joining us this morning.
Thanks. I actually went to hear this lecture yesterday. This lady at Milligan College, somebody drugged me over there, Jennifer Farr Davis. I don't know if you've heard of her, but she set the record. She speed hiked the AT a few years ago in 45 days. So that's pretty crazy. I am from the library, so I'm interested in all things health information. And we're coming over here for a while on Research Day. I don't know if we've been over here for a while lately, but we want you to know that we're a resource for you. And we liked coming over to do that just so you get to know us, and that would generate some database searches. So as I always do, I'm talking about some aspect of evidence-based practice and specifically evaluating the quality of information. I don't have anything to declare. The classic definition of evidence-based medicine is explicit and judicious use of best evidence, making decisions about the care of patients. It means your clinical expertise integrated with the best evidence, and also the patient's values. There's just all kinds of slides I could put up like this that aren't that great. This is from the New England Journal. It says that physicians adhere to recommended care guidelines 23% of the time for hip fractures, 25% of the time for AFib, 39% of the time for community-acquired pneumonia, 41% of the time for UTIs, and 45% of the time for diabetes. So there are some major issues that evidence comes into as far as problems with the American healthcare system. The average American receives care that fails to meet professional evidence-based standards about half the time. A Utah hospital started to adopt evidence-based practices, and they were able to boost patient survival rate for acute respiratory disease distress 4 times the national average, cut adverse drug events, including overdoses and allergic reactions, in half, cut the mortality rate for coronary bypass surgery to half the national average / hospital readmission rates for heart failure and pneumonia. This is kind of the picture of what the information world looks like right now. When this slide was made, it said that there was 1,800 new articles put into PubMed a day. Now that's up to 3,500. So you could probably double those others. The 7,000 is just in all the biomedical literature, not just PubMed. And the 75 is clinical trials. Now, I did study that for 2015, and it is up to about double that. So there's about 150 new clinical trials a day that you have to keep up with. This shows the growth of PubMed. So in 1996, there were 2 million abstracts in PubMed, and I counted it last year, there was 25 million. And that incremental growth is just going to continue throughout your career. This study shows that physician knowledge deteriorates over time. This was on hypertension done in Canada, and they decided on the gold standard. That was easy to do, and then they gathered how people treated it in a certain radius, and they found it was all over the map, and it was directly correlated to when they finished their training. Basically, they weren't learning anything new after they graduated. This study was really important. This guy identified 28 landmark trials that really changed the face of medicine. He said only 2 were adopted within 2 years. So there's a real slow pickup or adoption of new research that comes in to medicine. It's a very slow changing field. Now, that's a little bit of a background. I could go on all day with slides like that, unfortunately. But there are processes to help everybody be more evidence-based. And one of the things that people like to show across the world is a process called the 5A process. And it's basically like this. Assessing patients is something that you do every day. Well, out of those encounters, studies say that you generate quite a few clinical questions. And there's a proper way to do that that helps you get an answer. Then from there, you want to acquire a resource to answer that question. And then you want to be able to appraise that, and we're going to talk about that some today, and then to apply it to the patient. So those are the 5 A's. So you're assessing patients throughout every day of your life, and we'll be doing that for the rest of your career. So you have a natural curiosity to ask questions that come up with patients. And you want to construct a certain type of question that's relevant and answerable. So there's a system that's been developed around the world called PICO to do that. So you may be familiar with that. And it's mainly for foreground questions. So I'll show you the difference between a foreground and a background question. So basically, it's what's the problem? Some people say, what's the patient or the patient population? But I just say, what's the problem you're looking at? Second thing is, okay, what intervention are you trying to do? And then there may be a comparative intervention, something versus something. And then what outcome do you want? And you want to strive for a patient-oriented outcome. We'll talk about those in a second too, as opposed to a disease-oriented outcome. So you don't necessarily want to change the HDL number or the A1C number. You want to reduce mortality and morbidity and reduce costs and reduce length of stay and release symptoms, things that are important to you and to the patient. So PICO is a really good way to put a question together that's answerable. So when you're starting out as a student, mainly you're learning background material, and that will decrease throughout your career. And then as you get into your clinical practice, almost all of your questions will be foreground questions. And foreground questions are questions usually that are, there's two or more choices about a clinical decision. So should I use drug X or drug Y? Should I do this procedure or that procedure? And so those are what works with the PICO concept. PICO is done to focus the information need and to facilitate searching the literature. So when you think about doing a PICO, think about the literature. And the more you use PubMed, the more you'll realize it's built on a structure called MESH. And what you want to try to do is map the PICO term to the MESH term to get the maximum retrieval from your search. So here we have Angela. She's a healthy 50-year-old woman with early osteoarthritis in her knees, hips, and feet. She's been taking ibuprofen and is reluctant to be on a long-term medication. She asked you about possibly trying acupuncture for her arthritis. What is your recommendation? I know all of my examples are just sort of general medicine, so sorry they're not OB-GYN specific. So here you'd have your patient or problem would be just patients with osteoarthritis. You could say, elderly women or older women or midlife women or whatever, but that's probably not relevant. So it's just the patient or the problem is osteoarthritis. The intervention would be NSAIDs basically, and the comparative would be acupuncture. And then the outcome would be relief of symptoms. So that's how you would PICO a scenario like that. Okay, after you've asked a question, and you should be doing that throughout your day every day, and do it in an answerable format, you need to acquire information to answer that. So this little quote here I really like because it sort of talks about my profession, but when health professionals request lab work, they turn to medical technologists. If an x-ray is needed, they direct the patient to a radiographic technician. The reason is simple. Even though the clinician is certainly capable of learning and performing these tasks, higher quality and greater cost effectiveness are obtained by using the skills of specialists. Can the same not be said for the expertise and experience that librarians bring to the healthcare enterprise? So that's an open invitation to use me and my colleagues and the librarians here, Debbie, etc., to help you answer your clinical questions for no other reason than to save you the time that you lack. So please don't hesitate to send us as many questions as you have. We actually go to about 5 residency programs, morning reports once a week, and gather questions from them. I was just at family medicine in this hospital yesterday. So really there's 2 types of clinical literature, the primary and the secondary literature. And the secondary literature is really developed mainly because of the evidence-based medicine philosophy. And the secondary literature basically has been validated, and the primary literature has not. Primary is like journal articles, such as PubMed, textbooks. They're unfiltered for the quality of the evidence. Secondary literature is systematic reviews, the famous Cochrane database, evidence syntheses such as Dynamed, UpToDate, and article syntheses. And I don't know if there's one of these specifically for OB-GYN, but there's one that we subscribe people to called the Daily Poems, where they read 150 journals a week or a month, and then they take an article that could change the way medicine is practiced, and you get that as an email critically appraised. So this pyramid puts into sort of a hierarchy the types of literature that are out there today and sort of their value, their validity, and reliability. So at the top, something I'm not all that familiar with is systems, and I believe this is information that's tied into the EHR and that you can put individual patient values. So it's very patient specific, therefore very high level. Summaries are like UpToDate, Dynamed. They're critically appraised disease topics where the best evidence has been sorted out. So they've picked out the RCTs and the ones that are well done in the clinical trials and the systematic reviews, etc. Synopses are like the daily poems I described. So they're just describing one journal article that's very relevant and well done, and that's important to practice. Syntheses are like systematic reviews. So you take one topic, you gather all the, in the Cochrane studies, it's all the RCTs on that one topic, and you synthesize that. If you do it mathematically, it's a meta-analysis. So that red line is secondary literature. So everything above that, it's evidence that's been pre-filtered. So if you can use that to answer your clinical questions, that's great, because that means it's going to be a higher level of evidence. And a lot of that, there's apps for that you can put it on your smartphone. And if you need help with that, that's one service that we provide. So we'll be glad to help you with that. Again, I don't know if there's a lot of OB/GYN specific clinical apps for information. I'm not aware of any. And then below that line is the primary literature. So just individual studies, and finally on the bottom, expert opinion. You know, I don't think people quite understand evidence-based medicine sometimes. Even there's some pushback on it, which has always puzzled me. But I had a medical student once send me this article, and it was something that said basically the editor of the Lancet said half of all the medical literature was crap. And I thought, wow. I said, that's the field I work in. I really don't like that, you know. And the second thing I thought was, wow, they're the editor of Lancet. Why are they letting all the crap get through? You know, they should be fired. And then they quoted the editor of the New England Journal, and they said something similar. And then I started to think. I said, well, that's really not a bad thought, because if half of it's crap, well, the other half of it's good. And that's really what evidence-based medicine is. Medicine's always practiced with the literature, but they've never had until the last 20 or 30 years a system in place to sort out the high-quality literature, the wheat from the chaff, to use that in clinical practice. And that's exactly what evidence-based practice does. It identifies that 50%, even the top part of the 50%, so that you're not missing that in your clinical practice. So we would be glad to sit down and do any kind of PubMed training with you. Stuff like what mesh is, how to use limits, methodology types, how to go through the proxy server to have access off campus, how to use subheadings, and how to use the MAOM CBI component of it. Again, primary literature is also textbooks. We do have a strong collection of electronic textbooks through the library. Secondary literature, Essentials Evidence Plus is one. Dynamed is one that we promote. UpToDate we have, the hospital has. We may actually, I'll go ahead and start telling you this now, in a year from now, we may have to cut UpToDate, because of their cost. It's just gone up exponentially. Although we will definitely listen to people, and the hospital systems have it, so that would remediate that some. First Consult is another one. There's one called Clinical Practice put out by BMJ, and then ACP Smart Medicine are all secondary point-of-care tools. I like this. It's called the usefulness equation. So it says, I don't care how relevant and valid that the information is. You know, and relevance and validity are about truthfulness. So really, evidence-based medicine is a theological enterprise, because you, as clinicians, you're seeking the truth. And but the value is not going to be high if it takes too much work to get it. So it's important to learn ways to get the evidence that you need for patient care quickly. Okay, so all that was really the introduction. So the main thing I want to get to is the next step, which is appraising the literature. And this is the step that throws people off. It certainly scares me at times. First, I don't have the clinical knowledge that you all have, and then the sort of whole biostatistical world sort of scares us all. I even went and got an MPH in epidemiology and biostats to help me overcome some of my fears. I'm not sure it still did any good, but it's not that scary really. But you need to know how to read your own literature and praise the quality of it. So that's the next day is appraisal. And here's some reasons why. For years, physicians had prescribed antiarrhythmic drugs for heart attack patients, even though later research revealed that these drugs had killed more Americans in the Viet Cong. There's a group of people around the world that make a distinction between poems and does, and poems is not, I think that I shall never see a thing as lovely as a tree, although those are really nice. A poem stands for a piece of clinical literature that's patient-oriented, and it's evidence that matters. It matters to the environment that you're in, it matters to the patient, it matters to the physician. So mortality, morbidity, length of stay, reduced costs, relief of symptoms, etc. But, you know, a lot of sort of pre-evidence-based medicine days, you know, a lot of clinical decisions were based on DOEs, which were disease-oriented evidence, so stuff out of the lab. So I can't read my own slides, but anyway, like doxycycline for blood pressure, well, the lab evidence said it reduced blood pressure, but they actually found out that it increased mortality in African Americans. Arrhythmias following acute MIs. The logic in the lab said it was suppressed arrhythmias. They actually found out it increased mortality. Sleeping infants on their stomach or side. Well, they thought just based on anatomy and physiology that this would decrease aspiration. Actually, it increased the risk of sudden infant death syndrome. And vitamin E for heart disease, histamine antagonists and PPIs, hormone replacement theory, beta blockers for heart failure. All those, the disease evidence suggested one thing, and yet when they did trials in people, they found out the other. So that's another good reason to know how to have good evidence skills. And this is actually some more. I think some of those repeat what was on the previous slide, and I definitely can't read those, they're too small. So not only is there a hierarchy, which can be shown in a pyramid, of the various evidence products that are out there today, but at the very bottom of that was individual studies. So within that little slice of that previous pyramid, those can be actually put into a hierarchy as well. And so the top of that would be the clumping mechanisms, systematic review meta-analyses, but sort of forget about that right now. Of the individual studies, the most valid and reliable type would be an RCT, because it's an experimental methodology type, and all the others are observational types. And we'll see a little bit here in a second how that comes into play. So everything above that, at that red section and above is experimental. Everything below that's observational. And within observational studies, there's a hierarchy. So cohort studies are considered more reliable and valid than case control studies, which are superior to individual case series, which are superior to case reports. Then you have opinions, animal research, and test tube research. Not that any of those are bad. I think the Australian guy found out about infectious agents causing ulcers. That was a case study. Of course, the famous Framingham study, we know a lot about heart disease. It's still going on, started in 1948 in Framingham, Massachusetts, and so on. So don't think any of those are bad. You want to go with the best evidence. So here's another. I'm trying to leave you some practical things like PICO, like the 5 A's. Here's another one. I learned this at a evidence-based training I went to at Duke once, and it was called Frisbee. Most of the articles that you're probably going to evaluate have to do with treatment, probably 60% or so. Then the next greatest clump would be diagnosis, and then some prognosis and some harm. So since you're doing probably a lot of Frisbee article evaluation or therapy article evaluations, remember Frisbee. So you've got that article, you're doing it for Journal Club. Look to see what the follow-up rate was. Was it at least 80%? If not, you have to wonder, where'd those people go? Did they die? Was it randomized? And along with randomization, was there concealed allocation, which has to do with enrolling people in the trial. So the two of us were the enrollers, and we have people come up, and we shouldn't really know what arm we're assigning them to. We may have a bias, and we want the trial to come out this way, and somebody looks really sick, and we'll put them in the arm we want to come out the worst. So there should be concealed allocation. Intention to treat. Everybody should be analyzed in the arm of the trial that they started out in. The same at baseline. So, usually table 1 shows those characteristics, and all the demographics should be the same, because otherwise that could be causing the change in a group other than what the intervention is. Blinding. Is it single blinded? Do the patients not know what arm they're in? Is it double blinded? Do the clinicians not know? Is it triple blinded? Do the data analysts not know? Because they could actually bias the results on how they cook the numbers. And finally, were people equally treated throughout the trial? So FRISBE. You can remember that pretty clearly, and that gives you a tool right off the bat for analyzing articles on therapy in the literature. All right. Fortunately, we don't have to do all of the analysis ourselves, because there's been taxonomies created to sort of put a tag on a piece of information as far as its reliability and validity. Well, one of them is from the Oxford folks who do Cochrane, and it's this called LOEs, or levels of evidence. So this is like that previous pyramid I just showed you. So the level of evidence would pretty much be with the methodology type. So if it's a RCT, it's going to be a level 1. If it's a cohort, it's going to be a level 2. And you can see within those categories, like if it's a systematic review of multiple RCTs, that's a 1A compared to just an individual RCT. And there's a lot of, and I'm going to talk about this in a second, a lot of variance of how a study would be rated too based on the quality as well. A 3 would be a case control study, and a 4 would be a case series, and 5 expert opinion. So that's their system of rating evidence at Oxford. This one's called SORT, and it stands for Strength of Recommendation Taxonomy. So basically they have an A, B, and C. An A means the recommendations based on consistent and good quality patient-centered evidence. A B, it's recommendations based on inconsistent or limited quality patient-oriented evidence. And C, recommendations based on consensus and practice opinion and disease-oriented evidence. So something can become a, not showing the whole thing. They rate individual studies based on a level 1, a level 2, and a level 3. So a level 1 would be a good quality patient-oriented evidence, which basically means it's a validated clinical decision rule, a systematic review or a meta-analysis of high-quality studies, or a high-quality diagnostic cohort study. And a level 2 would be unvalidated clinical decision rule, systematic review, meta-analysis of lower quality studies or studies with inconsistent findings, or lower quality diagnostic cohort study or diagnostic case control study. I'm not sure what's cutting that off at the bottom, but I'm not even going to try to read that, level 3. So basically, when you are looking for evidence, you need to look for these recommendations. One criticism people have of up-to-date is you don't see levels of evidence or strength of recommendations generally throughout their individual disease reports. You see more of it in Dynamed and other point-of-care products. So, but this is basically kind of the philosophy that they use. Here's sort of the flow chart in their grading of evidence in the SORT recommendation. So they'll say first, is this a key recommendation? If it's not even worth rating, don't bother with it. If it is an important recommendation, is the recommendation based on patient-oriented evidence? That is, its improvement in morbidity, mortality, symptoms, quality of life, or cost. If it's not, it automatically gets a recommendation of C. But if the answer is yes, is the recommendation based on opinion, bench research, a consensus guideline, usual practice, clinical experience, or a case series study? So sort of low levels of evidence for individual studies. If the answer is yes to that, it gets a C also. But if you can still say no, you ask some more questions. Is the recommendation based on one of the following? A Cochrane review, which is a systematic review of multiple RCTs, United States Preventive Services Task Force, grade A recommendation, and there is a little app that you can put that shows what USPSTF recommendations patients need. Clinical evidence, which is a point-of-care tool produced by BMJ, a rating of beneficial, consistent findings from at least 2 good quality RCTs or a systematic review meta-analysis of the same, validated clinical decision rule in relevant population, consistent findings from at least 2 good quality diagnostic cohort studies or systematic reviews. So if it gets down to this box and it's no, it gets a B recommendation. If any of these are a yes, it gets an A recommendation. So when you see these recommendations and they're using the sort taxonomy, that's how they're getting that. And all this, is obviously somewhat subjective, but it's trying to identify the best evidence, and it's trying to work with your confidence level. So, you would have more confidence in applying an A recommended procedure than a B or a C. This is actually for individual studies, not for statements that are guidelines, etc. So is the study important? No. It's much like the other. Is the key outcome of the study based on patient-oriented evidence? If no, both of those are level 3. If yes, you keep going and asking more questions. Is it based on opinion, bench research, etc.? Again, gets a level 3. If it's any of these right here, it gets a level 1. If not, it's a level 2. And that's for individual articles. So usually the numbers are for individual articles and letters for recommendations for treatments, etc. So here are some examples where I actually didn't make my font too small that I couldn't read it, that apply sort. And there's other taxonomies other than sort, and they have the same sort of theory and philosophy behind them. So while a number of observational studies, which are level of evidence 2, observational studies, suggested a cardiovascular benefit for vitamin E, a large, well-designed RCT with a diverse population, level of evidence 1, showed the opposite. The strength of recommendation against routine long-term use of vitamin E to prevent heart disease based on the best evidence available should be A. So that shows you that it looked like from the observational studies that there was a cardiovascular benefit, but the RCT showed the opposite. So in this case, and because the RCT is well done and there's no RCTs that contradict that, it trumps the cohort studies as far as their recommendation. Here's another one. A Cochrane review finds 7 clinical trials that are consistent in their support of a mechanical intervention for low back pain. But the trials were poorly designed. They were unblinded, non-randomized, or with allocation to groups unconcealed. In this case, the strength of recommendation in favor of these mechanical interventions is B. So they use a high level of evidence here for RCTs, but they were A, inconsistent, and B, they had weaknesses in their methodology. So they get a recommendation level of B. So I just want you to understand some of the mechanics that go into these recommendations that govern the information that you use every day in practice. Here's another one. A meta-analysis finds 9 high-quality clinical trials of the use of a new drug in the treatment of pulmonary fibrosis. 2 of the studies find harm, 2 find no benefit, and 5 show some benefit. The strength of recommendation in favor of this drug would be B because there's inconsistency. There's 5, 2, and 2. So, this is a tough type of decision-making process that these folks have to make, throwing all this into the blender and mixing it up and coming out with a recommendation. Here's another one. A new drug increases the forced expiratory volume in 1 second, FEV1, and peak flow rate in patients with an acute asthma exacerbation. Data on symptom improvement is lacking. The strength of recommendation in favor of using this drug is C. And that's, even though that's a test that people feel that's very important, it's still a disease-oriented evidence. Therefore, because it's not showing changes in POEM evidence in human populations, the recommendation's only a C. So, I've moved through fairly quickly. I'm almost finished. Another, and maybe this might be the most well-known of all, taxonomy classification is GRADE. And this is a group of folks from all around the world. And you can see it's much like SORT. They have recommendations of A, B, C, and D. So further research is very unlikely to change the confidence in the estimate of effect. So you can have a lot of confidence in what this is saying. B, Further research is likely to have an important impact on our confidence in the estimate of effect and may change the estimate. C, which is a low rating, further research is very likely to have an important impact on our confidence in the estimate of effect and is likely to change the estimate. And D is a very low rating. Any estimate of effect is very uncertain. There's a whole, in the Journal of Clinical Epidemiology, series of 17 articles that the grade people explain how their system works. And I sort of tried to wade through those. Basically, they take RCTs, and that gives you a high-level rating. But then they have a whole series of steps that could be rated down. So, for example, some ways you could start with an RCT and be rated down. Does the article have a high risk of bias in the study? Is there inconsistency in their findings? So you found one study says this and one study says this and so on. Is there indirectness? I had to think about that for a while, but basically indirectness might be the study uses a time frame that's different from your time frame that your patient population you're concerned about. There's no head-to-head comparison is a form of indirectness. So you've got two drugs, and drug A, the trial is against placebo, and then drug B, the trial is against placebo. But there's not a trial of drug A head-to-head against drug B. So you have to infer things when there's indirectness. One concept that you hear a lot about, and this is a form of indirectness, is surrogate endpoints. So in like diabetes, the endpoint might be A1C as opposed to patient mortality, morbidity, etc. So a lot of times surrogate endpoints are used, and this is a form of indirectness. Another thing that would rate down an RCT a level would be imprecision. So when you see the results, you see the confidence intervals, and if the confidence interval is very wide, that might rate it down. And then there's a specific type of bias called publication bias. Mainly it's the positive studies that get published, and that can be a problem as well. So that's grade. There's lots of different kinds of practice guidelines. So for AHRQ, the Agency for Healthcare Research and Quality, they have an A, B, C, and X. And A says that there's good research-based evidence to support the recommendation. B, there's fair research-based evidence. C, the recommendation is based on expert opinion. I went to a workshop once at UVA, and they said that more and more guidelines are evidence-based, and they have strengths of recommendations and levels of evidence with them. But that wasn't always the truth. They said at one time guidelines were developed. Basically, NIH would get the most famous people in a field in a hotel room in Bethesda, Maryland, and the one with the strongest personality would beat the others in submission, and then that would be like the national guideline for clinical practice. The United States Preventive Services Task Force has a guide to clinical preventive service, so their recommendation of A means there's good evidence to support the recommendation. When they say good evidence, it'll be the same principles that I've shared today. It'll be based on RCTs, it'll be based on RCTs that are consistent, that don't have some of the drawbacks that I mentioned. B is there's fair evidence to support the recommendation. C, there's insufficient evidence to recommend. D, there's fair evidence to support the recommendation that the condition be excluded. So now it's going the other way. And then E, there's good evidence to support that the recommendation that the condition be excluded. So the recommendation can actually be harmful to the patient. So, and again, all this always is going to be integrated to your clinical wisdom and to your local environment and circumstances. It's never, a forced type thing. You have to always use your judgment. So, getting back to the 5 A's, the final thing you do is you apply that in the context that I just told you. You return to the patient. You integrate that evidence with your clinical expertise and the patient preferences, and you apply it to the practice in your local situation. Finally, one of my goals today is to give you some practical things, the 5 A's, the PICO, the Frisbee, but it's to strengthen your BS detectors as you read the literature. We'll say that B stands for baloney today because this is a family show. But some things to look for in articles are time orientation. So is it a prospective study, like most cohort studies are, or is it a retrospective study? Has it been randomized? What's the length of study? I know there's a controversy in study cutoffs. Actually, when I went to this workshop at Duke, Gordon Guyatt was the speaker there. He invented the term evidence-based medicine. I thought that was pretty cool. I got to hear somebody talk that did that. But he did a study on sort of early cutoff of trials. And he said a lot of the big journals will do that. And they'll have something, and they'll have actually phenomenal results after this endpoint. And they'll want to get it rushed, particularly New England Journal and JAMA. They'll want to get it published in the New York Times. And by golly, they'll cut that off. But then he showed examples where those trials had been continued, and the benefit is up here by the intervention. And then yet, if they extended it out in time, it started to do this. That the intervention actually over a longer period of time. So length of time is something to think about. Adequate inclusion and exclusion criteria, that's important when you're doing a systematic review, for example, of blinding. I told you there were single, the patients, double the clinicians, and triple the data analyst. And then there's concealed allocation when you're enrolling people in a trial. Appropriate biostatistical tests. You don't have to know how to take a piece of paper and a pencil and do multiple regression. I certainly don't know how to do that. But you should know, when should an odds ratio be used, when should a risk ratio, kind of what does it mean, what are appropriate values, what's a confidence interval, etc. Things that aren't all that hard. Is it experimental study versus an observational study? Is there a control group? And are the conclusions supported by results? All of us have a tendency to write something and then in the conclusion write this glowing final summation that you're going, well, that doesn't sound like the article I just read. In summary, that's the end. And my goal is to make you all Yodas. And a Yoda is someone who's your own data analyzer. So yes, you want to always, you would always like to have your attendings follow you throughout your career, but that's not possible. And so you're going to have to get to the point where you're going to make clinical decisions, and you're going to have to make those judgments, and you'll need those kind of skills to do that 5A process. You want to assess a patient, you're going to ask that question, you want to be able to acquire the literature, and hopefully you'll be in a setting that has access to the literature. Then you want to appraise that and separate the good evidence from the bad evidence, and you want to apply that for better patient outcomes. And that's all I got to say. Thank you. Yes, sir.
My biggest problem with evidence-based
Yeah.
is that the studies tend to be buffered instead of split.
Okay.
And what I mean by that is, you may study a population and try and make it as wide as possible. But stealing from today's news, it matters if you're evangelicals or white middle class or minority as to how you're going to vote in that study. And so if you don't separate people out, you miss things like Isodil, the drug works better in African Americans than it does in white Americans. And you're going to miss out on the fact that no female animal or human was ever used in the initial trial of those drugs. And that data just became available to the NIH. They didn't use female animals in the study. So I just worry a great deal that a lot of the stuff that's coming out is smoothed by using a huge population instead of making it appropriate to my particular patient.
Well, part of that I think would be, where indirectness comes in, where a form of indirectness would be, the patient population is not like your patient population. And, in that step that I mentioned there at the end where you apply that, you do use your clinical judgment, and you're not automatically saying, okay, because this is a level 1 recommendation, I do this. So, But then again, on the other side, I mean, if you take that all the way to the conclusion, is, you know, what if we didn't use evidence? And you know, and I showed you at the start where, you know, there's examples of that not being done that have had, you know, really bad outcomes. And two, I think, you know, you very much hit on a point that, you know, trialers and researchers need to take into consideration these populations that have been excluded. And you're absolutely right. You know, women have been cheated as far as, you know, studies that focus on their needs. Yeah.
I was going to say, I think there's a couple of things. There's a little mini revolution to fix some of the criticism. And the center around some really big themes that I'm hard to ask. But, you know, to add to some of your article analysis things like p-hacking. So journals are getting away from p-values and looking at other statistical methods for that besides the consideration of p-hacking. Standard says 70% of our response. Well, and that's probably a good assessment, but Mdiv introduces Bayesian probabilistic reasoning into the analysis of studies. So he's assigning pre-study probabilities to the hypothesis and analyzing the evidence that supports it in view of the Bayesian regression. So to me, almost every criticism of Mdiv goes away if we limit the use of frequentist statistics to data that's of that sort, and we introduce Bayesian probabilistics to all the other data, including the critical reasoning. And we're just not teaching, it's not widely done. It's being done now in the last 5 years, but not widely done. It's using Bayesian reasoning to assess data. But that's where the stuff like Mdiv is coming from. But we get p-hacking because we're inappropriately using frequentist methods to analyze statistics that have been better suited if they're analyzed by Bayesian. So, from my perspective, I see a revolution in the next 10 years where journals are going to move away from some of those inappropriate statistical methods. And I think people who criticize it will actually appreciate it when they see that their clinical experience and whatever does matter, because they have to do things like assess pre-test or pre-study probabilities in order to come up with a Bayesian result. So there's a whole industry that criticizes it. But all of them fall away, I think, just with 2 or 3 simple changes on the area. And people want to use a clinical experience, and they want to look at an article and say, does this make sense or not? Well, Mdiv tells them, yeah, it does. So if the pre-study probability was only 2%, who cares what the p-value is? It's just, you know, p-value. And of course, he's published methods for discrete determinants of the post-study probability is based on everything methodologies for determining post-study probabilities. But all that's Bayesian, and it's been stood assaulted by frequentist statistics who are still worshiping for Ray Fisher and don't want some of these new things that are with quantum mechanics and every other field of science to enter into biological statistics.
That sounds like maybe a future grand rounds to.
There's 2 kinds of statistics. So the frequentist statistics are from Fisher, who was a geneticist, and this was data with works for very discrete data. Like Dr. Wells saying, they want this black and white stuff because they're using Fisher statistics that have 2 discrete, very nice outcomes. But in Bayesian statistics, which is almost replaced all of Fisher statistics in normal non-biologic sciences, says that what your pre-study with pre-test probability is influences the post-test probability. So it's the same way we interpret clinical tests. And we accept that, and all of, you know, he's got tools that you can put on your phone, and you put in the pre-test probability of whatever the disease is, pulmonary embolism, and then you get back a positive result for post-test probability. That's Bayesian statistics, but we should actually use Bayesian statistics for all of our data, is what people like to do.
It's appropriate in a lot of the data, not appropriate in all of the data.
Right, there's discrete data.
That's where the journals are not 70% of the probability is bad, because you either have a misdesigned study group or you have inappropriate statistics or you have something else that makes it not happening.
Or just a
The problem,
normal.
the next problem though is even the 30% that's good literature, if it disagrees with what we think clinically, we disregard it. And it takes, you know, a minimum of a decade for a good study to actually go into clinical practice.
Which is data.
So, and what, you know, in some ways, to Dr. Wallace's point, you know, we'll take a study and say, you know, we had a very small trial, it seemed to have some clinical evidence, we put it in a randomized clinical trial, and proved it doesn't work. Well, maybe it worked in that subset of the population, but we don't have the power to go back and show that it works. But the truth is, until that power is there and until that subset is working, you gotta go with large. Because it doesn't, or we'll put it into the trial. And we're evidence-based medicine, everybody wants to say, but it doesn't apply to me all the way.
But people have the opposite tendency too. People get their Google News feed that says vitamin D does this based on retrospective cohort, or not even that, just based on data. Of course, the statistics, misusing the wrong kind of statistical methods, and then next day they go in and give their patients vitamin D. And then 10 years later, or vitamin D for cardiovascular disease, and then 10 years later, the RCT says it actually works. So people don't wait for the right kind of data, but then people also don't use the right kind of data.
Do you think there needs to be a reform in the journals too, as far?
There already is. There are
Right.
already journals not accepting studies with p-values because they want to see whether statistical methods that measure effect. You can do a large enough study to p-hack anything with statistical significance. But if there's not a noticeable, if there was a noticeable clinical effect that really benefited patients, you wouldn't need a p-value to demonstrate that statistically. So there are journals that have changed their editorial policies already. They won't accept studies that use p-values as a measure of statistical significance.
That was one of the things that bothered me.
Yeah.
You know, a guy who's been working on a project for 3 years. He's got all this data. He goes to the statistician. The statistician says, well, let's find the test that will be most valuable for showing that your data is valid. And they'll change their statistical analyses basically on the initial null hypothesis. It's very suspicious of all that.
And that's almost an ethical concern there too. I mean, you know, that, I mean, if they're just starting, it's just look, they're trying to find positive results no matter what, you know. Yeah, because, you know, that gets into publication bias because you publish stuff with positive results, but it seems like actually evidence-based medicine is doing its job because it's actually led to this.
What I was really trying to say is that people, you can be dismissive and you can take the identities and say, hey, it's all junk Google and I'm
Right.
just going to do whatever I think. And throw the baby out with the bathwater. Or you can recognize that, gosh, if you're not going to try to do evidence-based medicine, what are you left with?
Right.
You're left with something that's from a much smaller data set, meaning your own experiences.
Right.
Much greater bias, meaning your own bias.
Exactly.
So you have no choice but to use the collective experiences.
And try to improve that.
Right.
Right, on all levels. I mean, I guess even conferences could maybe, you know, sort of step up, and as far as the presentations that they allow, start having a little bit stricter guidelines. And then on the other end too, it's just on your end educating you to have your BS detector so that you're aware of all these things that were pointed out, and that you have these skills, particularly with the statistical aspect of it. I do think there's hope. I do think there's ways to, you know, practice on a high level of truth and find best evidence. And I think the research enterprise will, you know, continue to churn out exciting discoveries. Yeah.
Just quickly on up to date.
Uh-huh.
Right, the hospitals do carry it.
Right.
There was some kind of negotiation between the right.
Yeah.
Frankly, up to date is written by 2 presidents straight out of their Republicans.
Right.
And they don't use good scientific analysis of the information. It's nice. Generally tends to be relatively up to date, but it's not necessarily evidence-based medicine.
Right. And they're really not that up to date. There was one study of some Cochrane collaborators in Italy, and they took all the point of care tools, and they actually found out that up to date didn't do that well. What they judged it by was they looked at all the new, I think it was systematic reviews that came out like in 6 months, and see which ones Dynamed up to date, Essentials Evidence Plus, etc., got those into their references within 3 months, 6 months. I think Dynamed did the best. They had like 80% within 3 months, and Up to Date had like 20% within 6 months or something. So, and even the best of those actually doesn't have, there's always a lag between what's published and what's in these point of care tools. Well, that was a good discussion.